Foundations of Maternal Newborn and Women's Health Nursing by Murray, McKinney, Holub, and Jones, 7th edition, Chapter 16, Intrapartum Complications. For most women, birth is a normal process that is free of major complications. However, complications sometimes make childbearing hazardous for the woman or her baby. The nurse's challenge is to identify complications promptly and provide effective care for such mothers, while nurturing the entire family at this significant time of life. The complications addressed in this chapter are often interrelated. For example, a dysfunctional labor is likely to be prolonged, and the woman is more vulnerable to infection, psychological distress, and fetal compromise. Also, women who have complications are more likely to need interventions such as lengthy hospitalization before vaginal or cesarean birth. The nurse should provide nursing care that relates to all problems experienced by the woman. Dysfunctional labor. Normal labor is characterized by progression of cervical effacement, dilation, and fetal descent. Dysfunctional labor is one that does not result in normal progress. A dysfunctional labor may result from problems with the powers of labor, the passenger, the passage, the psyche, or a combination of these. Often this type of labor is prolonged but may be unusually short and intense. An operative birth, assisted with a vacuum extractor or forceps or cesarean birth, may be needed if dysfunctional labor does not resolve or compromise occurs with the fetus or mother. Signs of possible compromise include persistent abnormal fetal heart rate patterns, fetal acidosis, and meconium passage. Maternal infection or exhaustion can also occur with a long labor. Nursing measures that enhance labor progress, maternal comfort, and promote fetal well-being are discussed in this chapter. Problems of the powers. The powers of labor may not be adequate to expel the fetus because of ineffective contractions or maternal pushing efforts. Ineffective contractions. Effective uterine activity is characterized by coordinated contractions that are strong and numerous enough to propel the fetus past the resistance of the woman's bony pelvis and soft tissues. It is not possible to say how frequent long or strong labor contractions must be. One woman's labor may progress with contractions that would be inadequate for another woman. Possible causes of ineffective contractions include the following: maternal fatigue, maternal inactivity, fluid and electrolyte imbalance, hypoglycemia, excessive analgesia or anesthesia, maternal catecholamines secreted in response to stress or pain, disproportion between the maternal pelvis and fetal presenting part, uterine overdistension such as with multiple gestation or hydramnios, excess volume of amniotic fluid, poor application of the presenting part to the cervix. Two patterns of ineffective uterine contractions are labor dystocia and tachysystole. The characteristics and management of each are different, but each results in poor labor progress if it persists. Labor dystocia. Labor dystocia means a difficult labor and may be used to describe any form of dysfunctional labor. However, it is most often used to describe labor that does not progress as expected. When labor dystocia or failure to progress occurs, contractions are coordinated but too weak to be effective. They are infrequent, brief, and when palpated, they can be indented easily with fingertip pressure at the peak. Labor dystocia, or secondary arrest, occurs during the active phase of labor, when progress normally quickens. The active phase usually begins by 6 centimeters of cervical dilation. Uterine overdistension is associated with labor dystocia because the stretched uterine muscle contracts poorly. The woman may be fairly comfortable due to weaker contractions. However, she often is frustrated because labor slows at a time when she expects to be making faster progress. Labor dystocia is tiring as a result of the duration of labor. Fetal hypoxia is not usually seen with dystocia. Management depends on the cause. Many women respond to simple measures. Administration of adequate IV or oral fluids corrects maternal fluid and electrolyte imbalances or hypoglycemia. Maternal position changes, particularly different upright positions, favor fetal descent and promote effective contractions. The woman who actively changes positions typically has better labor progress and is more comfortable than the woman who remains in one position. Standing or sitting in a shower provides the comfort of warm water and an upright position. Pain management techniques, such as epidural block, may have outcomes that reduce the effectiveness of contractions, requiring interventions specific to that factor. Effective pain management may, however, improve the progress of labor. The nurse should use therapeutic communication to help the woman identify anxieties or beliefs about labor and its progress. Identifying her anxieties is important because the stress response could slow her labor. For example, the nurse might ask, "What do you think is making your labor slow?" Or "How do you feel your labor is going?" Measures such as amniotomy and oxytocin infusion may be needed to promote labor progress. The birth attendant evaluates the woman's labor to confirm she is having labor dystocia rather than a prolonged latent phase of labor or false labor. The maternal pelvis, fetal presentation, and position are evaluated to identify abnormalities. Reducing undesired maternal effects of a prolonged latent phase, such as exhaustion or infection, is a goal of the birth attendant. However, the birth attendant should consider the possibility a woman is in false labor rather than in prolonged latent phase when choosing interventions to correct the labor progress. Amniotomy or augmentation, usually with oxytocin, may be used to stimulate an established yet slow labor pattern. The risks of amniotomy include umbilical cord prolapse, infection, and placental abruption, premature separation of placenta. Reduced placental perfusion caused by excessive uterine contractions is the most common risk for labor augmentation using oxytocin. Tachysystole. Tachysystole can be either spontaneous or induced and is defined as excessive uterine activity. Tachysystole is more than 5 contractions in 10 minutes, average over 30 minutes. In addition to tachysystole, contractions lasting 2 minutes or longer, contractions with less than 1 minute resting time between, or failure of the uterus to return to resting tone between contractions via palpation or intrauterine pressure above 25 millimeters of mercury, measured by an IUPC, may also be of concern. Contractions may be uncoordinated and erratic in their frequency, duration, and intensity. Although each contraction varies in its intensity, the uterine resting tone, uterine muscle tone, when not having contraction, between contractions may be higher than normal, reducing uterine blood flow. The reduction of blood flow to the uterus decreases fetal oxygen supply and causes the woman to have almost constant cramping pain. With a high uterine resting tone and complaints of continuous pain, the nurse should be alert to a possibility of placental abruption, as the symptoms can be the same. The mother becomes very tired because of nearly constant discomfort. She loses confidence in her ability to give birth and cope with labor. She often thinks, "If it hurts this much so early, I must be a real baby about pain." Frustration and anxiety further reduce her pain tolerance and interfere with the normal processes of labor. Cervical dilation should not be equated with the amount of pain a woman should experience. Management of uterine tachysystole depends on the cause. If oxytocin is being administered, the dose should be decreased or stopped. Oxytocin can intensify the already high uterine resting tone. Secondly, relief of pain is an important intervention to promote a normal labor pattern. In the latent phase of labor, warm showers and baths promote relaxation and rest, often allowing a normal labor pattern to ensue. Systemic analgesics, or occasionally low-dose epidural analgesia, may be required to achieve this purpose. Tocolytic drugs, drugs that inhibit uterine contractions, may be ordered to reduce uterine resting tone and improve placental blood flow. The decision to order uterine stimulant or relaxant drugs is very individualized based on each woman's labor pattern. Ineffective maternal pushing. A reflexive urge to push with contractions usually occurs as the fetal presenting part reaches the pelvic floor during second stage labor. However, ineffective pushing may result from the following: use of non-physiologic pushing techniques and positions, fear of injury because of pain and tearing sensations felt by the mother when she pushes, decreased or absent urge to push, maternal exhaustion, analgesia or anesthesia that suppresses the woman's urge to push, psychological unreadiness to let go of her baby. Management focuses on correcting causes contributing to ineffective pushing. There is no limit for the duration of the second stage of labor as long as the woman and fetus are stable with normal vital signs and FHR patterns. Each woman is evaluated individually by her birth attendant to determine whether labor should be ended with an operative delivery or can continue safely. Nursing care to promote effective pushing helps the mother make each effort more productive. Most women, including those with epidural analgesia, can detect the urge to push. The practice of laboring down or delayed pushing, encouraging the woman to wait until she feels the reflexive urge to push, has shown a lower incidence of adverse effects than pushing immediately on full cervical dilation. Upright positions such as squatting add gravity to the woman's pushing efforts. Semi-sitting, side-lying, and pushing while sitting on the toilet are other options. If she prefers to lie in bed on her side, she should pull her upper leg toward her chest with each push. Leaning forward while in the sitting position or squatting position maintains the best alignment of the fetal head with the pelvis. The woman who fears injury because of the sensation she feels when pushing may respond to accurate information about the process of fetal descent. If she understands that sensations of tearing often accompany fetal descent, but her tissues can expand to accommodate the baby, she may be more willing to push with contractions. Epidural analgesia for labor uses a mixture of local anesthetic agent and epidural opioid analgesic to provide pain control without the major loss of sensation that is likely if local anesthetic is used alone. However, if a woman cannot feel the urge to push at all or cannot feel it strongly after the fetus has descended, she can be coached to push with each contraction. The woman who is exhausted may push more effectively if she is encouraged to rest and push only when she feels the urge, or she may push with every other contraction. Oral and IV fluids can provide energy for the strenuous work of second stage labor. Reassuring her about fetal well-being and the fact that she has no absolute deadline to meet helps her work with her body's efforts most effectively. This reassurance also helps the woman who may be emotionally readying herself to let go of her fetus in exchange for a newborn as she labors. Problems with the passenger. Fetal problems associated with dysfunctional labor are related to the following: fetal size, fetal presentation or position, multifetal pregnancy, and fetal anomalies. These variations may cause mechanical problems and contribute to ineffective labor. Fetal size. Macrosomia. The macrosomic infant weighs more than 8 pounds 13 ounces or 4,000 grams at birth, although some authorities define it as a weight of 9 pounds 15 ounces, 4,500 grams or greater. The head or shoulders may not be able to adapt to the pelvis if they are too large. Cephalopelvic disproportion. In addition, distension of the uterus by the large fetus reduces the strength of contractions both during and after birth. Size, however, is relative. The woman with a small or abnormally shaped pelvis may not be able to deliver an average size or small infant. The woman with a large pelvis may easily give birth to an infant heavier than 8 pounds 13 ounces, 4,000 grams. Fetal position as the baby descends through the pelvis is another important factor in terms of fetal size and maternal pelvic size. Use of different maternal positions that open the pelvis may promote vaginal delivery. Positions that promote the C-curve of the spine, in which the patient leans and shoulders forward and causes the spine to curve forward, directing the fetal pressure towards the back of the pelvis rather than the front, narrower part of the pelvis. Use of labor balls, large inflated physiotherapy balls, or a firm foundation to sit on will cause the pelvic diameter to increase. Use of side-lying positions with a peanut ball, a peanut-shaped labor ball, between the knees can allow the sacrum and coccyx to fall further back, increasing the pelvic diameter. Shoulder dystocia. Delayed or difficult birth of the shoulders may occur as they become impacted above the maternal symphysis pubis. Shoulder dystocia is more likely to occur when the fetus is large or the mother has diabetes, but many cases occur in pregnancies with no identifiable risk factors. Labor may be long, but shoulder dystocia also may occur after a normal labor. Shoulder dystocia is an urgent situation because the umbilical cord can be compressed between the fetal body and the maternal pelvis. One of the initial signs of shoulder dystocia is known as the turtle sign. After the head is born, it retracts against the perineum, much like a turtle's head drawing into its shell. When the turtle sign is identified, the delivery team should make preparations for surgical delivery, which should be anticipated while taking immediate steps to deliver the baby vaginally. Although the infant's head is out of the vaginal canal, the chest is inside, preventing respirations. Any of several methods may be used to quickly release the impacted fetal shoulders. McRoberts maneuver is a nursing action that should be taken immediately, pulling the mother's knees up as far towards the shoulder as possible. Fundal pressure should be avoided so that the shoulders are not pushed even harder against the symphysis. Suprapubic pressure may assist in moving the impacted shoulder past the symphysis. The provider will take other measures to effect delivery. After delivery of the infant, the clavicles should be checked for crepitus, deformity, and bruising, each of which suggests fracture. Documentation of all care is essential, including a clear description of the maneuver used to assist with delivery. One person is usually designated the timekeeper for accuracy of records. Abnormal fetal presentation or position. An unfavorable fetal presentation or position may interfere with cervical dilation or fetal descent. Rotation abnormalities. Persistence of the fetus in the occiput posterior or occiput transverse position can contribute to dysfunctional labor. These positions prevent the mechanisms of labor, cardinal movements, from occurring normally. Most fetuses that begin in the occiput posterior position rotate spontaneously to the occiput anterior position, promoting normal extension and expulsion of the head. The fetus may not rotate or may partly rotate and remain in the OT position. Although many women cannot readily deliver a fetus in the OP position, the woman with a pelvis larger than the fetal size may be able to do so. Labor usually is longer and more uncomfortable when the fetus remains in the OP or OT position. Intense back or leg pain that may be poorly relieved with analgesia makes coping with labor difficult for the woman. Back labor aptly describes the sensations a woman feels when her fetus is in the OP position. Some women who had a fetus in the OP position during labor continue to feel more pain in the back, or coccyx, during the postpartum period. Maternal position changes promote fetal head rotation to the OA position and descent. Examples include the following. Hands and knees. Rocking the pelvis back and forth while on hands and knees promotes rotation. The woman's knees should be slightly behind her hips in this position. A peanut ball may aid in helping a patient feel supported. A dense epidural may interfere with the use of this position. Side lying, on the opposite side of the fetal occiput, especially when in the far side lying position with the posterior shoulder pulled behind the patient and the upper knee touching the bed. A peanut ball may be used in the side lying position to open the pelvis. Squatting for second stage labor. Sitting on a slightly underinflated birth ball gives a similar effect. Sitting, kneeling, or standing while leaning forward. Upright maternal positions promote descent, which usually is accompanied by fetal head rotation. The hands and knees and side-lying positions promote rotation because the mother's abdomen is dependent in relation to her spine. In the hands and knees position, the convex surface of the fetal back tends to rotate toward the convex anterior uterus, similar to nesting of two spoons. The side-lying position has a similar effect, although not quite as pronounced. These positions decrease the mother's discomfort by reducing the pressure of the fetal head on her sacrum. All variations of the squatting position aid rotation and fetal descent by straightening the pelvic curve and enlarging the pelvic outlet. They add gravity to the force of maternal pushing. If spontaneous rotation does not occur, the physician may assist with the rotation and descent of the head by manual rotation or using forceps. The vacuum extractor cannot always be applied to the fetal head when it remains in the OP position. However, some styles of vacuum extractors may be used to correct minor degrees of malrotation because the fetal head tends to rotate as it descends with downward traction. Cesarean birth may be needed if these methods are unsuccessful or cannot be used. Deflection abnormalities. The poorly flexed fetal head presents a larger diameter to the pelvis than if flexed with the chin on the chest. In vertex presentation, the head diameter is smallest. In military and brow presentations, the head diameter is larger. In face presentation, the head diameter is similar to that of vertex presentation, but the maternal pelvis can be traversed only if the fetal chin mentum is anterior. Breech presentation. Cervical dilation and effacement often are slower when the fetus is in breech presentation because the buttocks or feet do not form a smooth, round, dilating wedge like the head. The greatest fetal risk is at the head, the largest fetal part. It is the last to be born. By the time the lower body is born, the umbilical cord is well into the pelvis and may be compressed. The shoulders, arms, and head should be delivered quickly so that the infant can breathe. A breech presentation is common well before term, but only 3 to 4% of term fetuses remain in this presentation. Reasons for a breech presentation may include the following: low birth weight as a result of preterm gestation, multifetal pregnancy, or intrauterine growth restriction. Fetal anomalies contributing to breech presentation, such as hydrocephalus. Complications secondary to placenta previa or previous cesarean birth. External cephalic version, ECV, may be attempted to manually move the fetus in breech presentation or transverse lie to cephalic presentation. If the fetus remains in the abnormal presentation, cesarean section usually is performed to avoid complications. Birth for the nulliparous woman with a fetus that remains in breech presentation is almost always by cesarean section. The fetus remaining in a transverse lie is delivered by cesarean section as well. Some women are admitted in advanced labor with the fetus in breech presentation, so birth attendants and intrapartum nurses should be prepared to care for the woman having either a planned or an expected vaginal breech birth. Multifetal pregnancy. Multifetal pregnancy may result in dysfunctional labor because of uterine overdistension, which contributes to labor dystocia and abnormal presentation of one or both fetuses. Similar to a large overstretched rubber bands, the overdistended uterine muscle does not contract evenly or with great force. In addition, the potential for fetal hypoxia during labor is greater because the mother must supply oxygen and nutrients to more than one fetus. She is at greater risk for postpartum hemorrhage resulting from uterine atony because of uterine overdistension. Some patients with twin A in the vertex position may have a vaginal delivery. Because of risk for cord prolapse, placental shearing, and potential bleeding problems, many women with multifetal pregnancies opt for cesarean birth. If 3 or more fetuses are involved, the birth is almost always cesarean. The physician considers fetal viability, fetal presentations, maternal pelvic size, and presence of other complications such as preeclampsia or chronic hypertension when determining the best plan of care for the patient and her fetuses. Each twin's FHR is monitored during labor. When in bed, the woman should remain in the lateral position to promote adequate placental blood flow. After vaginal birth of the first twin, assessment of the second twin's FHR continues until birth. The delivery staff should be prepared for the care and possible resuscitation of multiple infants. Radiant warmers, resuscitation equipment, medications, and identification materials should be prepared for each infant. 1 or more neonatal nurses, a neonatal nurse practitioner, and a pediatrician or a neonatologist should be available to care for each infant. 1 nurse should be dedicated to caring for the mother. Fetal anomalies. Fetal anomalies such as hydrocephalus or a large fetal tumor may prevent normal descent of the fetus. Abnormal presentations such as breech or transverse lie also are associated with fetal anomalies. These abnormalities often are discovered by ultrasound examination before labor. Cesarean birth is scheduled if vaginal birth is not possible or is inadvisable. Problems with the passage. Dysfunctional labor may occur because of variations in the maternal bony pelvis or soft tissue problems that inhibit fetal descent. Pelvis. A small, contracted, or abnormally shaped pelvis may retard labor and obstruct fetal passage. The woman may experience poor contractions, slow dilation, slow fetal descent, and a long labor. 4 basic pelvic shapes exist, each with different implications for labor and birth. Most women do not have a pure pelvic shape, but instead have mixed characteristics from 2 or more types. Maternal soft tissue obstructions. During labor, a full bladder is a common soft tissue obstruction. Bladder distension reduces available space in the pelvis and intensifies maternal discomfort. The woman should be assessed for bladder distension regularly and encouraged to void every 1 to 2 hours. Catheterization may be needed if she cannot urinate, or if epidural analgesia depresses her urge to void. There are mixed opinions in the literature as to whether intermittent catheterization or Foley placement is more appropriate. Problems of the psyche. Labor is a stressful event for most women. A perceived threat caused by pain, fear, non-support, or personal situation can result in impaired coping ability and interfere with normal labor progress. Responses to excessive or prolonged stress interfere with labor in the following several ways. Increased glucose consumption reduces the energy supply available to the contracting uterus. Secretion of catecholamines, epinephrine and norepinephrine, by the adrenal glands stimulates uterine beta receptors, which inhibit uterine contractions, an action similar to that of tocolytic drugs, such as terbutaline. Adrenal secretion of catecholamines diverts blood supply from the uterus and placenta to the woman's skeletal muscles. Labor contractions and maternal pushing efforts are less effective because these powers are working against the resistance of tense abdominal and pelvic muscles. Pain perception is increased, and pain tolerance is decreased, further increasing maternal anxiety and stress. Assisting the woman to relax helps her body work more effectively with the forces of labor. Nursing measures may involve the following: establishing a trusting relationship with the woman and her significant other, making the environment comfortable by adjusting temperature and light, identifying coping measures the patient finds useful, promoting physical comfort such as cleanliness, providing accurate information, implementing non-pharmacologic and pharmacologic pain management. Abnormal labor duration. An unusually long or abnormally short or precipitous labor may result in maternal, fetal, or neonatal problems. Prolonged labor. Reasons for prolonged labor are multifaceted. If a previous birth was by cesarean section before significant cervical dilation occurred, the criteria for labor progress of a nullipara may be most appropriate. Effects of epidural analgesia on labor characteristics and the rate of progress in descent should also be considered by the birth attendant when deciding if interventions are needed to increase progress. Traditional thought based on the Friedman curves developed in the 1970s indicated that after the woman reached the active phase of labor, cervical dilation should proceed at a minimum rate of 1.2 centimeters per hour in the nullipara and 1.5 centimeters per hour in the parous woman. The fetal presenting part was expected to descend at a minimal rate of 1 centimeter per hour in the nullipara and 2 centimeters per hour in the parous woman. New data have come to light with the results of a study by Zhang, Landy, Branch et al. 2010 with the Consortium for Safe Labor, a 2010 trial funded by the National Institute of Child Health and Human Development. This multi-center retrospective study abstracted detailed labor and delivery information from electronic medical records in 19 hospitals across the United States. A total of 62,415 patients were selected who had a singleton-term gestation, spontaneous onset of labor, vertex presentation, vaginal delivery, and a normal perinatal outcome. They found that normal labor may take over 6 hours to progress from 4 to 5 centimeters and over 3 hours to progress from 5 to 6 centimeters of dilation. Nulliparas and multiparas appeared to progress at a similar pace before 6 centimeters. However, after 6 centimeters, multiparas accelerated much faster than nulliparas. The 95th percentile of the second stage of labor in nulliparas with epidural analgesia was 3.6 hours, and without epidural analgesia was 2.8 hours. They concluded that allowing labor to continue for a longer period before 6 centimeters of cervical dilation may reduce the rate of intrapartum and subsequent repeat cesarean births in the United States. Although these data are becoming increasingly more accepted in the obstetrics community, no practice changes have been made with standards for fetal monitoring assessment and documentation because there is no evidence that a change is indicated. Possible maternal and fetal problems in prolonged labor include the following: maternal infection, intrapartum or postpartum; neonatal infection, which may be severe or fatal; maternal exhaustion; higher levels of anxiety and fear during a subsequent labor. Maternal and neonatal infections are more likely if the membranes have been ruptured for a prolonged time because organisms ascend from the vagina. Nursing measures for the woman who has prolonged labor include promotion of comfort, conservation of energy, emotional support, position changes that favor normal progress, and assessments for infection. Nursing care for the fetus includes observation for signs of intrauterine infection and compromised fetal oxygenation. Precipitous labor. Precipitous labor is one in which birth occurs within 3 hours of its onset. Intense contractions often begin abruptly rather than gradually, increasing in frequency, duration, and intensity, as is typical of most labors. Precipitous labor is not the same as precipitous birth. A precipitous birth occurs after labor of any length, in or out of the hospital or birth center, when a trained attendant is not present to assist. However, a woman in precipitous labor also may have a precipitous birth. If the physician or nurse midwife will not arrive in time for the baby's birth, the nurse should wear gloves and simply support the infant's body as it emerges. If the maternal pelvis is adequate and the soft tissues yield easily to fetal descent, little maternal injury is likely. However, if the soft tissues are firm and resist stretching, trauma, vaginal wall lacerations, cervical lacerations, sulcus or vulvar tears, and hematoma of the vagina or vulva may occur. Several conditions that can be associated with precipitous labor include placental abruption, fetal meconium, infection, maternal cocaine use, postpartum hemorrhage, and low APGAR scores for the infant. Trauma from rapid labor may result in genital tract lacerations in the mother and neonatal birth injuries. The fetus may become hypoxic because intense contractions with a short relaxation period reduce the time available for gas exchange in the placenta. Abnormal electronic fetal monitoring patterns may include bradycardia and late decelerations. The fetus may suffer direct trauma such as intracranial hemorrhage or nerve damage during a precipitous birth from the sudden release of pressure on the fetal head. Priority nursing care of the woman in precipitous labor includes promotion of fetal oxygenation and maternal comfort. The side-lying position enhances placental blood flow and reduces the effects of aortic cable compression. An added benefit of the side-lying position is to slow the rapid fetal descent and minimize perineal tears. Additional measures to enhance fetal oxygenation include administering oxygen to the mother and maintaining adequate blood volume with non-additive IV fluids. If oxytocin is being used, it should be stopped. A tocolytic drug may be ordered. Promoting comfort is difficult in a precipitous labor because intense contractions give the woman little time to prepare and use coping skills such as breathing techniques. Pharmacologic measures such as analgesics or epidural block may not be useful if rapid labor progress does not allow time for them to become effective. Possible newborn respiratory depression should be considered if opioid analgesia is given near birth. The nurse assists the woman to focus on techniques to cope with pain, one contraction at a time. The nurse should remain with her to provide support and assist with an emergency birth if it occurs. Several patient problems may be appropriate when caring for a woman having dysfunctional labor. The potential complication of fetal compromise should be part of all intrapartum management. Pain management is especially important to women in labor because they may find their coping skills are inadequate or difficult to use because of fatigue, possibly to the point of exhaustion. Anxiety or fear often is higher with abnormal labor, which limits the woman's ability to cope with labor. Anxiety or fear may reduce the effectiveness of pain medications or regional block analgesia. In addition to these problems, nursing care is directed toward two other patient problems: possible intrauterine infection and maternal exhaustion. Possible intrauterine infection. Infection can occur with both normal and dysfunctional labors. The labor nurse should be familiar with the criteria for III, intrauterine inflammation or infection or both, and the protocols or order sets that are in place in their institution. III is also known as chorioamnionitis, intraamniotic infection, IAI, or intrauterine infection, IUI. III is proposed as the preferred term as it is more general and descriptive. The following parameters meet the criteria for a diagnosis of III for the mother. Maternal fever, defined as an oral temperature of 39.0 Celsius or greater, 102.2 Fahrenheit, on one reading, or 38.0 Celsius, 100.4 Fahrenheit, or greater, but less than 39.0 Celsius, 102.2 Fahrenheit, on two readings, 30 minutes apart, with one or more of the following: fetal tachycardia, baseline greater than 160 BPM, times at least 10 minutes, maternal white blood cell count greater than 15,000 in the absence of corticosteroids, purulent fluid emanating from the cervical os, cloudy yellowish thick discharge confirmed visually on sterile speculum examination to be coming from the cervical canal, biochemical or microbiologic amniotic fluid results consistent with microbial invasion of the amniotic cavity. Confirmed testing includes the following: positive gram stain for bacteria, low amniotic fluid glucose. Note: if only maternal temperature is elevated with no other markers, it is not III. Fever plus one indicator equals suspected III. Fever plus confirmed testing equals confirmed III. Assessment. Assess maternal temperature every 2 to 4 hours in normal labor and every 2 hours after the membranes have ruptured. Assess the temperature hourly if elevated or other signs of infection are present. Assess maternal pulse, respirations, and blood pressure hourly if elevated temperature. Assess amniotic fluid for normal clear color and mild odor. Small flecks of white vernix are normal in amniotic fluid. Yellow or cloudy fluid or fluid with a foul or strong odor suggests infection. The strong odor may be noted before birth or afterward on the infant's skin. Identification of patient problems. For the woman without signs of infection but with risk factors, the patient problem identified is potential for infection because of the presence of favorable conditions for development. The nurse may specify the patient-specific conditions that may cause infection when choosing the patient problem. Planning. Expected outcomes. Expected outcomes relate to detecting the onset of infection. Maternal temperature will remain below 38 degrees Celsius, 100.4 Fahrenheit. The FHR will remain near the baseline with an average baseline rate no higher than 160 BPM. The amniotic fluid will remain clear and without a foul or strong odor. Interventions. Reducing the risk for infection. Nurses should wash their hands before and after each contact with all patients to reduce transmission of organisms. Limit vaginal examinations to reduce transmission of vaginal organisms into the uterine cavity and maintain aseptic technique during essential vaginal examinations. The intrapartum nurse learns to estimate a woman's progress with few vaginal examinations. For example, increased bloody show and heightened anxiety may occur when the cervix is approximately 6 centimeters dilated. The patient may have nausea or vomit at 7 centimeters. The woman may become irritable and lose control at about 8 centimeters dilation if she has chosen not to have epidural analgesia. Keep underpads as dry as possible to reduce the moist, warm environment that favors bacterial growth. Periodically clean excess secretions from the vaginal area in a front-to-back direction to limit fecal contamination and promote the mother's comfort. Use personal protective equipment to avoid contact with body secretions. Identifying infection. Assess the woman and fetus for signs of infection. Increase the frequency of assessments if labor is prolonged, if other risk factors are present, or if any signs of infection are found. If signs of infection are noted, report them to the birth attendant for further evaluation and treatment. Note the time at which the membranes ruptured to identify prolonged rupture, which adds to the risk of infection. After birth, the attendant may collect specimens from the uterine cavity or placenta for culture to identify infectious organisms and determine antibiotic sensitivity. Aerobic and anaerobic culture specimens may be collected in containers specifically made for these two types of organisms. Follow directions on the container for proper handling and prevention of contamination with extraneous organisms, which would result in inaccurate results. Transport specimens to the laboratory promptly because living organisms are required for culture and sensitivity study. Antibiotic therapy is started without delay after collecting specimens. Inform the newborn nursery staff if signs of infection are noted or increased maternal risk factors exist. Specimens of infant secretions also may be obtained for testing before administration of antibiotics. The infant may receive prophylactic antibiotics to prevent neonatal sepsis. If results of maternal or infant cultures indicate that no infection is present, the antibiotic is discontinued. Culture and sensitivity testing may reveal an infection and indicate that a different antibiotic would be more effective, in which case the antibiotic is changed. Evaluation. The goals and expected outcomes are achieved if the following occur. The woman's temperature remains below 38 Celsius, 100.4 Fahrenheit. The amniotic fluid has no abnormal characteristics that are typical of infection, cloudiness, yellow color, foul or strong odor. The FHR remains within the expected range, not showing tachycardia, whether sudden or gradual in onset. Even if the woman has no signs of infection, she remains at higher risk for postpartum infection and should be observed for signs and symptoms of infection. Maternal exhaustion. Assessment. Many women begin labor with a sleep deficit because of fetal movement, frequent urination, and shortness of breath associated with advanced pregnancy. As labor drags on, the mother's reserves are further depleted. Some women do not choose to or cannot have epidurals. Even with epidural analgesia, the long labor drains the mother's energy. Therefore, the labor nurse should be prepared to deal with exhaustion. Assess the mother for the following signs of exhaustion. Verbal expression of tiredness, fatigue, or exhaustion. Verbal expression of frustration with a prolonged, unproductive labor. I can't go on any longer. Why doesn't the doctor just take the baby? Ineffectiveness of or inability to use coping techniques, e.g. pattern breathing, that she previously used effectively. Changes in her pulse rate, respiration, and blood pressure, increased or decreased. Identification of patient problems. The intense energy demands of a dysfunctional labor may exceed a woman's physical and psychological ability to meet them. For this reason, exhaustion due to depletion of maternal energy reserves is an appropriate patient problem. Planning. Expected outcomes. Contractions must continue for labor to progress. Two realistic goals or expected outcomes are that the woman will do the following: rest between contractions with her muscles relaxed, use coping skills such as breathing and relaxation techniques effectively. Interventions. Conserving maternal energy. Reduce the factors that interfere with the woman's ability to relax. Lower the light level and turn off overhead lights. Reduce noise by closing the door or using soft music, water sounds, or other comforting sounds. Maintain a comfortable maternal temperature with blankets or a fan. If not contraindicated, a warm shower or bath is soothing. Position the woman to encourage comfort, promote fetal descent, and enhance fetal oxygenation. Support her with pillows or birth balls to reduce muscle strain and added fatigue. Help her change positions regularly, about every 30 minutes, to reduce muscle tension from constant pressure. A soothing back rub reduces muscle tension and thus decreases fatigue. Firm sacral pressure and use of some maternal positions may reduce back pain. Using the birthing ball can relax and support her in some positions. Warmth to her back can reduce back pain. Maintain IV fluids at the rate ordered to provide fluid, electrolytes, and possibly glucose. Assess intake and output to identify dehydration, which may accompany prolonged labor. Dehydration also may cause maternal fever. If not contraindicated, provide juice, lollipops, frozen juice bars, or other clear liquids, as ordered by the physician or nurse midwife, to moisten the woman's mouth and replenish her energy. Promoting coping skills. When position changes or medical therapies are used to enhance labor, explain their purpose and expected benefits. Encourage the woman to visualize her baby passing downward smoothly through her pelvis as a result of her efforts. Provide mental images that allow her to see herself giving birth. Generous praise and encouragement of the woman's use of skills, such as breathing and visualization techniques, motivate her to continue them even when she is discouraged. As with any laboring woman, tell her when she is making progress. Tell her that FHRs and patterns are reassuring if this is true. Knowing that her efforts are having the desired results and her fetus is doing well gives the woman courage to continue. Evaluation. Goals are met if the woman does the following: rests and relaxes between contractions. She is unable to relax and feels she needs help. Discuss alternative coping methods, including analgesia options with her. Continues to demonstrate adequate use of learned skills to cope with labor. Premature rupture of membranes. Rupture of the amniotic membranes before onset of true labor is called premature rupture of membranes, PROM, regardless of gestational age. A precise term, preterm premature rupture of membranes, PPROM, sometimes abbreviated as small p, PROM, refers to the rupture of membranes earlier than 37 weeks, with or without contractions. PPROM is associated with preterm labor and birth. The greatest risks to the newborn occur with birth before completion of 32 to 34 weeks of gestation. Etiology. Several conditions are associated with PROM and PPROM, but the exact cause often remains unclear. Conditions associated with preterm ruptured membranes include the following: triple I may be associated with group B streptococcus, Neisseria gonorrhea, Listeria monocytogenes, or species from the gonorrhea Mycoplasma, Bacteroides, and ureaplasma in the amniotic fluid. Infections possibly asymptomatic of the vagina or cervix, such as N. gonorrhoeae, chlamydia, trachomatis, trichomonas vaginalis, GBS, or Gardnerella vaginalis, bacterial vaginosis. Amniotic sac with a weak structure. Previous preterm birth, especially if preceded by PPROM. Fetal abnormalities or malpresentation. Incompetent cervix or a short cervical length, 30 millimeters or less. Overdistension of the uterus, such as multiple gestation or polyhydramnios. Maternal hormonal changes. Maternal stress or low socioeconomic status. Maternal nutritional deficiencies and diabetes. Complications. Both mother and newborn are at risk for infection during the intrapartum and postpartum periods. Infection can be both a cause and a result of PROM. Organisms that cause triple I weaken the amniotic membrane, leading to the rupture. The mother is at higher risk for postpartum infection, and the newborn is vulnerable to neonatal sepsis. Triple I, characterized by maternal fever and uterine tenderness, is most likely to precede preterm birth in the infant born before 34 weeks of gestation. Preterm infants with the lowest maturity, such as 23 weeks of gestation, have higher risk for the infection than preterm infants who are even a few weeks more mature. The exact time at which infection occurs cannot be predicted for either term or preterm infants. Frequent performance of digital examination of the cervix increases the risk for all gestations. If III does not precede PROM, it is more likely to occur if a long time elapses between membrane rupture and birth because vaginal organisms can readily enter the uterus. The risk for III is known to increase when the membranes are ruptured for 24 hours or longer. Membranes that rupture before term may form a seal, stopping the fluid leak and allowing the amniotic fluid to become reestablished. However, membranes may continue to leak, resulting in low levels of amniotic fluid, olighydramnios, prolonging the loss of the amniotic fluid cushion for the fetus. Umbilical cord compression, reduced lung volume, and deformities resulting from compression may occur. The earlier in gestation the rupture occurs, the greater the risks associated with prolonged olighydramnios. If preterm birth occurs, the infant is more likely to have respiratory distress syndrome, RDS, and complications related to prematurity. The hazards of prematurity are greatest before 34 weeks of gestation, especially if the woman did not receive steroids to accelerate fetal lung maturation before birth. Therapeutic management. Management of PROM depends on the gestation and whether evidence of infection or other fetal or maternal compromise exists. If the fetus is less than 36 weeks, therapeutic management is more complex and may involve short-term tocolytic medications to delay delivery until steroids can be administered to enhance fetal lung maturity, and antibiotics can be started to reduce transmission of bacteria, including GBS. Risks for infection or preterm birth complications are weighed against risks of labor induction or cesarean birth. For a woman at or near term, 37 weeks of gestation or more, PROM may herald the imminent onset of true labor. Determining true membrane rupture. The first step is to verify ruptured membranes. Urinary incontinence, increased vaginal discharge, or loss of the mucus plug can be mistaken for ruptured membranes. A digital vaginal examination is avoided, particularly if the gestation is preterm and no evidence of labor exists. Instead, a sterile speculum exam is performed to look for a pool of fluid near the cervix and estimate cervical dilation and effacement. A pH test or Fern test may be done on the fluid to verify that the liquid is amniotic fluid. Tests are available that check for the presence of placental alpha microglobulin 1, PAMG1, found only in amniotic fluid. Tests to assess fetal lung maturity and identify infection are often performed. A transvaginal ultrasound examination may be performed to measure cervical length. A short 25 millimeters or less cervix is more likely to continue effacement and dilation even if the gestation is far from term. Serial abdominal ultrasounds will follow fluid levels and fetal growth status. Gestation near term. If labor does not begin spontaneously, the woman's pregnancy is at or near term, her cervix is favorable, and fetal lungs are mature, labor is usually induced. See Chapter 15. If the cervix is not favorable and no infection is evident, induction may be delayed 24 hours or longer to allow cervical softening and administration of antibiotics. Steroids to accelerate fetal lung maturity are not indicated if the fetus is 37 or more weeks of gestation. If induction is unsuccessful, or if infection or other complications develop, a cesarean birth is most common. The nurse should remember, however, that cesarean birth also increases the risk for maternal infection after birth. Preterm gestation. If the gestation is preterm, the physician weighs the risks for maternal fetal infection against the newborn's risk for complications of prematurity. Many variables should be considered by the physician and woman to determine the best course of management. Medical management changes as fetal maturation and conditions of the mother and fetus change with the continuation of pregnancy. The cervix usually is not favorable for induction far from term. Factors such as gestational age, amount of amniotic fluid remaining, fetal lung maturity, and any signs of fetal compromise are considered. A cerclage, suture encircling the cervix, may have been placed earlier in the pregnancy to prevent premature cervical dilation. If infection is not already present, the physician should consider whether leaving the cerclage in place is likely to increase the risk for infection. If no evidence of infection exists and the fetal lungs are immature, the woman usually is observed for infection or onset of labor in the hospital. Expectant management. Daily non-stress tests are performed to watch for FHR non-reactivity, which may occur with intraamniotic infection. Biophysical profiles, in which sonographic evaluation is added to the non-stress test, may be done 1 or more times per week. Fetal lung maturity testing may be done as term approaches to identify the best time for delivery unless other complications require delivery before fetal lung maturity. Antibiotics are given during labor.